Welcome to the Living Medicine podcast, where we talk about ethical medical use of psychedelic psychotherapy, teaching skills, examining the issues, and interviewing interesting people. Now let's start today's show. Hello, everyone. Thanks for joining us again. This is Signe, one of your hosts for Living Medicine. And as you guys know, if you've been listening along, our audience is particularly people who are interested in psychedelic medicine, but from the clinical side. So though we've interviewed researchers and people on the policy side, you guys know that our mission is particularly to speak to clinicians and people who are going to be actually doing the work. So I'm really excited today to talk to someone who has some of the most important messaging in the field right now for those of you who are starting out in psychedelic-assisted psychotherapy. So I want to introduce Derek Rinaldo, and I'll let him talk a little bit about himself. Derek is a longtime psychedelic medicine practitioner. He's also a breathwork provider and can speak a little bit about that if we have time. He is certified through the Living Medicine Institute program with us, as well as MAPS and Lycos's available trainings. And he's also holds a certificate in psychedelic therapy and research through the California Institute of Integral Studies, right? Derek has a private practice, and he has been heavily involved in a long time also with a sort of peer support for providers in the psychedelic space. So thank you for coming on. Yeah. I really appreciate having you.
Thanks, Signe.
So we are planning to talk a little bit today about a topic that you and I both agree is underrepresented in the conversations out there. For our audience's sake, I'll remind you that I'm one of the founders and runners of a training program for therapists that are getting into psychedelic medicine. And so we see cohort after cohort of very enthusiastic people who are often very skilled clinicians, but want to get into this space. Yeah. And there's a huge amount of enthusiasm, and there's a huge amount of sort of jumping in. And one of the things you and I have talked about is that we notice that in the public sphere, and also even in some of these conversations in the programs themselves, there's often not enough discussion about the dangers. And I think we have a shared concern about new providers kind of jumping into the space.
Yes.
Not quite ready for encountering these kind of situations, or also doing harm, because they haven't thoroughly been prepared or thought through what harm looks like on psychedelics. So, right. But why don't we start by you telling us a little bit about yourself and how it comes to be that you and I are the ones having this conversation?
Well, a little bit about myself. So I have, as a youth, I dabbled around in psychedelics and learned a lot. Some of it was just being out in the woods with friends and going to festivals here and there, and always it seemed like I walked out of there sometimes with difficult experiences, but just a lot of personal growth. And just as years went on, I realized how impactful it's been in my life, and seen it being impactful in other people's lives. And as I became a licensed mental health therapist, it was an area that I really wanted to really explore and get training in and do it right. So that's sort of where this all kind of started. I had started a peer support group with other therapists who were also working with psychedelics and ketamine use particularly. And so it's been really helpful to learn with other therapists and people in general. So, and in my private practice, gosh, over the past 7 or 8 years, I've probably had 5 or 6 people a year contact me because they've had what they've called really bad trips and persistent problems afterwards, months afterwards, or just not getting a whole lot out of it like they wanted to. And so some of that post-experience integration, has been from let's get more out of this to, wow, we've really got to deal with some adverse effects. So it's been really concerning for me.
That's interesting. So there's almost 2 categories: people who have been harmed, if just to use that word, and then others who are maybe haven't been skillfully prepared or assisted with integration
Yeah.
and are kind of
That's,
just dangling out there without any resolution. I don't want to put words into it, but
yeah. Yeah.
okay.
Yeah. And, I think there's a lot of attention that may not be paid towards proper screening and
Hmm.
preparation and the treatment or use of, and then, post experience integration that could really either just make it a whole lot more meaningful and
Hmm.
generalize into their life experience or to really help resolve, some really adverse experience afterwards. So,
Yeah. And to be clear, these are people who have done psychedelic work with other providers and
correct.
are
Yeah.
then coming to you almost as a corrective
Yes.
measure, looking
Yes.
for support.
And the because psychedelics have kind of gone mainstream, so to speak,
Yeah.
and I think, like you said, there's a lot of enthusiasm, and there's people who uh, I think I hate to like
Yeah. We just got to be real here because,
unconscious
yeah.
incompetence, I'm going to call it, who like
Yes.
I went to Peru and I did this ayahuasca thing and I really made a big impact in my life and I want to help people. Fantastic. So then they come back and maybe they did some little training here or there, but maybe not a lot of experience. And they talk to somebody and say, yes, I can be your healer, I can be your guide or facilitator. And then it's not really managed properly and well enough, at least, you know.
Yeah.
Um,
I like that term unconscious incompetence. I would agree with that because I
yeah.
think we all can appreciate that everyone out there doing this work, which is a rapidly growing amount of people now that the
Yes.
ketamine assisted psychotherapy is really, coming more into mainstream recognition and there are more and more providers stepping into it. Some
Yep.
of them trained by myself, so I'm aware
Yeah.
this is an exponentially growing group of people.
Yep.
Um, we can all sort of appreciate that everyone's heart is in the right place.
Absolutely. For
But
sure.
there also, I think, is a little bit of a naivete about what's involved
Mm,
and
mm,
what maybe you may be opening up when you
right.
step into this work with someone. And so I've also witnessed the kinds of things that I think you have, and some,
Yeah.
I also feel very compelled to get that message out there.
Yeah.
Um, so it sounds like and obviously, you are also a psychedelic provider. So you also do this work. You're not only working with people who are almost needing
Right.
repair, you're also working
Exactly.
with clients that are coming to you to do the original work.
Yep.
Um, it sounds like you're referring to categories of harm, which we can kind of talk about what the patterns are you're showing up. And then
Yeah.
also people who, like as you referenced, are just like put a lot of resources into getting this work done and then it's just not optimized in a way it's not useful,
Right.
and
Yeah.
I'm imagining a sense of like deflation or frustration or
Yeah. Yeah.
like I failed at this or this didn't work for me or is
Mhm.
that uh,
Yeah, that's what I'm finding too. And just to speak to some of the mainstreaming, I recently looked on Hulu and Netflix and Prime and Apple, and there's a lot of shows about psychedelics. And I did a sort of a little random scan through a bunch of them,
yeah,
and overwhelmingly, very few of them touch upon harm. And most of them really idealize how fantastic it is and how healing and all of these things, and a lot of different traditions too.
hmm
So I hope people can be discerning as they're getting information from mainstream places, podcasts or wherever, and looking at there are a couple podcasts about harm reduction with psychedelics, which are good.
yeah,
So and
and
at
that
festivals, for example, there are harm reduction tents like with Zendo Project or Dance Safe or something, so harm is happening.
mhm.
Adverse events are happening. So, yeah.
Yes, and always have. There's been an
Exactly.
underground world where this has been going, as we know, psychedelic work, good, bad, and in between has been going on for a long time. And those of us in the community have always known that it's possible to cause harm with this. It's
Mm,
just become, I don't want to say, maybe a challenging dialogue in the public sphere right now. as we saw
Right.
presented with even like the Lycos research going through the FDA
Yeah.
process, where um, there seems to be sometimes perhaps an accidental polarization in the public dialogue. Those that are like, this is going to save the world, this is the best thing ever, this is going to fix everything. And then
For
those,
everybody.
yeah, everybody,
This,
this is the
yeah.
solution for exactly.
Yeah.
Or, there are some camps that are like, this is terrible and
Yeah.
shouldn't happen at all because they are very aware that harm has been done. And
Yeah.
I think those of us who are in training programs or in conscientious practice, like yourself, we have to appreciate there's a both and
Yes.
only solution. And I'm
Yeah.
speaking now from someone who trains therapists to do this, is to train people to understand that yes, it's powerful work, and also don't be um, overconfident.
Hmm.
Very, very cautious about dotting your I's and crossing your T's with all of the like safety pieces. And
Yeah.
um, so what are some of those safety pieces? There are some just universal things that sort of ethical providers understand. Um,
Yeah.
and I think, why don't we just break it down into some sort of categories of things that you have seen go wrong?
Mm.
Um, One that you and I have talked about is like inadequate screening or people who really
Yeah.
should be doing it at all. Can you speak to what you've
Sure.
seen with that?
Well, one of the so there's research that shows that people who have had prior um, bad trips,
Yeah, in quotes.
with intense fear and anxiety, and then they try it again, they're more likely to have continued bad trips. So I've worked with a couple of folks who like said, yeah, when I was younger, I did these psychedelics and it was really hard. I didn't do it for a long time, and here I am trying it again and had a bad trip again.
Hmm.
So and there's some research that shows, like that that can happen. And that's not to say just because you did have a bad trip when you were 25 and now that you're 40 that you will have a bad trip. That doesn't mean that, but there is some tracking there.
Maybe those people should be approached differently, or
Yes, exactly. Yeah,
particular or different precautions being put in
yeah,
place.
yeah. And
Have,
screening wise, there needs to be, some look at just underlying conditions like schizophrenia or schizotypal sort of features. Intense fear and anxiety going into it, family history of schizophrenia, bipolar. These are things that would probably get screened out in many studies. They are. There's physical health risks to consider. Cardiac conditions. Um, yeah, if there's like seizure conditions that might be part of someone's experience. Um, and then other drug interactions if someone's on some other like serotonin drugs or MAO drugs inhibitors. Um, those would probably need to be screened through.
yeah,
Um,
especially depending on the medicine they're going to be taking.
yeah, exactly. Um, and then, there could be an increased risk of just poor judgment on the person who's with medication in them. And, having, there's an increased risk of accidents or injuries that could happen. Someone could get really behaviorally out of control. You know,
Mhm.
I've heard of people like sexually acting out, people getting aggressive.
Mhm.
So, yeah.
And these are things that when people are coming in telling you that I've had this kind of aversive experience, these are the kinds of things that you're being told they've
Mhm.
experienced or witnessed or okay.
Yep. Yep.
Yeah.
Yep.
Um, have you ever worked with someone who has had a prior bad trip? And I know you sort of put quotations around that when you said it,
Yeah.
um, and are coming in with fear, and then successfully then done medicine work with them? Or do you discourage them from doing it? Where do you land with that?
Mm. I I don't I wouldn't discourage them, but I think it would need to be handled very, very carefully
Hmm.
if they're going to do it. And there's some tropes out there like the medicine only gives you what you need and at the time, or there's no such thing as a bad trip. And I
Right.
think I don't think those are really helpful with
Right. Try
someone
saying that to someone who is feeling
who,
traumatized from
yeah, exactly. Um, so yeah, I don't discourage that, but I think those need to be really handled very carefully, regarding,
yeah.
the mindset going in, the setting, of course, the relationship with the sitter, or the shaman, or the facilitator or therapist.
Hmm.
Uh, that's a really important aspect of the experience in the setting. Yeah.
And one thing I have found myself doing in those cases in the ketamine clinic, because it is so titratable,
Mm,
is putting them on really low amounts, super,
yeah.
super low,
Yeah.
and letting them have some sort of agency about when they go up or down so that they can
Yeah.
feel themselves. Like we have this whole conversation on like, we can lean into it a little. Now you can pull back out. You can lean. And of course,
Exactly.
a lot of psychedelics don't have that kind of flexibility. But if you have an IV administration where you can literally dial it down or up,
Yeah.
it sometimes is reparative for people to feel like, oh, okay, I can collaboratively decide this with my
Mhm.
therapist. I can
Yeah.
back out at any moment, and I can use my own curiosity to explore it at my own pace
Yeah.
and kind of work with the fear that shows up there based on this prior traumatic experience I had,
Yes,
and
yeah.
kind of get into a relationship with that. And I think, having witnessed that working for people, it just reinforces to me how, that's not available in a lot of settings, but how just
Right.
putting that person right back on a what we would think of as like a full or regular psychedelic dose, and then
Yeah.
have it could be, I don't think that that would go well. So I can imagine that what you're saying is correct.
Yeah.
Um,
I often actually have encouraged somebody if they're sometimes people come to me and say, "Hey, I want to do this thing with somebody else that is going to do some kind of psychedelic thing." And I say, "Well, if you're going to do this, what you might want to do is try doing some breath work first to have some kind of non-ordinary state experience,
that's a
just
great,
to see how that feels for them."
yeah, that's a
And
great,
if they are going to go do something, start low. There's some people who are just like, I want to hit the heroic dose and really get out there. And I call them bliss chasers.
yeah. And
And
so it's
so,
interesting, like some of this you're saying makes total sense from a clinical point of view. And I imagine that a lot of listeners would be like, yeah, I totally get it. Start low. Someone has had a scary experience.
right,
Um, but I think it's important to note that a lot of providers in the space don't necessarily have that philosophy or encourage people to go low. Some do and
right.
some don't, because as you named, there's a lot of beliefs out there.
Yeah, sure.
Um, and I think there's definitely some providers out there that would encourage people to just blast through their fear or things along those lines.
So, I mean, especially since the 60s when psychedelic use sort of became more culturally open, from research that was done in the 50s and 60s. There's really it's rare that people have adverse effects, actually.
Mhm.
Um, but people do. So that's the thing. And so maybe most people will be okay, even if they have a hard time. They'll be okay. And there's some factors to help people get through those things.
Mhm.
Uh, but people's difficulties usually resolve. Uh,
Yeah,
so,
it's interesting. I mean, I think the fact that actually most people are okay, and even
uh,
with challenging content, is also valuable. Those are
yeah,
some of the tropes out there that we actually agree with, right? I actually do
yeah,
think
yeah.
challenging content is very valuable. That's not
Yep,
the same as
absolutely.
a bad trip. And most people actually do well. Um, that is the case, but that because that is the case, I think that also leads to this under reporting of the people that don't do well. They are the
Right.
minority, but
Yeah.
if you are stepping into this space and going to be a provider and you don't have skills or you don't have the ability to screen or track or watch for this,
Yeah.
it's going to happen and you're going to be responsible. And
Yes.
I think this is why you and I we keep tooting this horn. Like, um, And so we'll talk a little later about maybe for our audience is therapists or medical providers, clinicians that are starting to do this work. Maybe we
Yeah.
can talk a little bit later about ways to mitigate against that or get supervision or, what do you need to do to make sure that you're not going in naive about it? Because what I see a lot is, yeah, your first 10 or 20 people will do great. Maybe even your first 99 people will do great.
Exactly.
And so
Exactly.
you go, oh, okay, I got this. And then
Mm,
you run into
mm,
someone where you really mishandle it and harm is caused.
yeah.
And that one is too many. It's so
Yeah.
if you can be taught skills for that, then that
And I've worked with a couple folks in town who have had experiences that with other providers who have have experience in whatever tradition they are,
yeah.
and then they're left with like, I'm the one person that this person didn't handle properly, you know.
Uh
They're left with this like persistent hallucination problems, or actually triggering some latent schizophrenia. I've had someone who fell into some psychosis afterwards and had to be hospitalized. I've had people with increased suicidal ideations and from people in town.
mhm.
So, yeah,
And when you say people in town, you mean people with reputations for knowing what they're doing.
yeah,
And it's sort of a reinforcing that this is just their, I know I'm almost saying this over and over again, but maybe that's what needs to be heard is that no matter how trained you are and no matter how comfortable you are with these medicines,
yeah,
some people get hurt by them. And
yeah,
so, what are you then going to do? How are you going to screen for that, which is what you've spoken to already? And
yeah,
then, how are you going to do something different for preparation and integration? But also, how are you going to get those people resources um, and stay with them? The fact that they're coming to you, Derek, is emblematic to me that the original provider isn't really staying with them through this
yeah.
process, this
And
process of
this
harm
This is
and
exactly what's
repair.
happened with probably 4 or 5 of my cases is that, well, we did the thing and we did a couple integration sessions and now we're done.
Right.
Then this
It,
person that a month later is having panic attacks or feeling suicidal. So
that's I think that's extremely important.
yeah,
I
yeah,
think they're one of the biggest problems in education in the space right now is a lack of emphasis on integration as an ongoing
yeah,
thing. Like
right,
in our training, we have a curriculum unit on this where like the kind of catchphrase is like, because there's a lot of question, how many integration sessions do you do? 3? Do you do 5? And we have this, you do it until you're done. Like
right,
you stay with the client until
yeah,
there's no residual symptoms and there's no residual like concerns. And
yeah,
that might, for some people, be a long time. It's not for most,
yeah,
but for some it is. And especially if they're coming up with a lot of challenging content, then that really is your responsibility.
yeah,
So, I mean, maybe one of the biggest messages you and I need to get out there is follow up with your people and
hmm,
continue the integration process. And if you need to bring in medical or other providers, have a network for that.
yeah,
The
exactly,
psychiatrists or, have a
yeah,
resource network for that because it is actually your responsibility.
hmm,
You are the person who has given them, the medicine and taken them through this challenging thing. And if something is cracked open in them or some symptoms have been triggered that they're not safe and not okay, I
yeah,
think that's where the lack of ethics can come in. But I agree with you with this where you said it's like unconscious incompetence.
hmm,
I, People are not trained to know what to do with that, so they just kind of say, "Oh, sorry, uh, that doesn't
yeah,
usually happen. Don't know what to
right.
tell you." Is that? I mean, that's been
Yes,
my
and then
experience.
I don't know what to do. And then I think people are kind of left like, oh, shit, I don't know what to
Yeah,
do now with this. Even if they like, so, okay, we did our 3 integration sessions, and you're off on your own, and the person calls back, and then the person's like, oh, okay, I don't know what to do now.
yeah.
I
I don't have a tool set for
don't know how
this.
to handle this. Yeah, So,
Yeah, it strikes me as a double harm in a way, because there's the symptom that the person is actually struggling with, which could be quite dangerous or concerning. You mentioned increased suicidality or psychosis. I mean,
yeah,
these are very serious like safety pieces,
yeah.
but there's also, I would imagine, this real like relational betrayal, maybe because you put this
Yeah.
trust in this person to take you through this very vulnerable thing.
Which can be,
Yeah.
like we're really vulnerable in um, a deeper way, and childhood stuff can come up, and hopefully it does, but hopefully it's resolved. But if it's not, and something like childhood abandonment issues or trust and stuff, that can really surface and stay and stick.
Yeah,
Um,
I can
but
imagine just a lot of like attachment wounding and just psychological harm in addition to psychiatric or other types of emergencies coming up.
yeah, yeah,
Um, just, just to reiterate, doing this work is relationally very intense, right? So there's,
yes, yes.
um,
I might do a 2 hour ketamine session with somebody, and that could be tiring, on our end.
yeah.
Uh, so
So you're seeing, I think, some of the things I'm seeing. And but I think you are working with a little bit more of these people proportionally to your practice than maybe some of us are. Why do you think that is? Do you think people have just, heard that you're someone who understands this?
I think it's just word of mouth that it's come through to me. I don't even have anything like this on my website. I
Yeah.
am on like the MAPS Lycos integration website. And I've gotten several people, that have come to me through that.
Because I imagine you didn't start out thinking, I'm going to have a practice with working with people who are harmed by psychedelics.
No, no, I didn't. Yeah, so I think it's word. I mean, I know some of it is word of mouth at least. Yeah, and I think on my website it talks about that I do ketamine assisted psychotherapy, and I think some
Mhm.
people just like, oh, this guy, well, maybe he knows about this stuff too. You
Yeah.
know, so
Yes,
yeah.
and to be clear, both of us are ketamine providers, but we also will often get clients coming into our practices who have had experiences with other psychedelics and other
Oh
kinds
yeah,
of
yeah,
things. And so
yeah,
when, this conversation is sort of speaking to psychedelics globally,
yeah.
though I have
I've
certainly,
had folks come to me because actually more of my folks come probably because they just something happened at a festival, you know, and they've actually had like pretty significant psychedelic use, and then they were at a festival once, and
Mhm.
2 months later they're still having panic attacks. So that's where a lot of my people come from,
Yeah.
as well as people who have gone to other providers and experienced persistent problems afterwards that weren't resolved or integrated. So
Yeah, so there's some categories. There's sort of
yeah,
unsupervised non-clinical use, and then there's supervised use by providers that just get a little bit in over their head, maybe.
yes,
You can say that.
yeah,
Yeah.
yep, yep,
Yeah, we run a very medically monitored clinical type of psychedelic work using
hmm
ketamine, and we have, I mean, almost none of these kinds of outcomes. And
yeah,
it's almost a little bit of sounds like a little artificial thing to say, like, oh, we never see these bad outcomes. But I really think it's a monitored clinical setting, but there's a lot of preparation and a
right.
lot of integration. And there's no, the integration can go on for a very long time and then therapists are skilled to work with that content. Um,
And there's a lot of like direct attention and care, to that person in a controlled setting, right? As opposed to being at a festival or a party or running around out in the woods with friends. You might not get that kind of attention on you. And, if psychedelics can really poke unknown suffering that's held in your pain body, and
yeah,
so if you're at a festival and something comes up, but that's not the context for it. And so you're probably going to push it down and suppress it, right?
yes.
Right. And then just go on dancing or whatever. And then afterwards, that surfaced a bit, that bubbled up.
Yep.
People
And then
can be,
you just feel unsettled or raw or
yeah, yeah,
symptomatic, and you don't even know for sure why because you don't have a story to attach to it. But something's
exactly.
off. Yeah.
Something came up and it wasn't the right time or place. So I pushed it away, but it was big. And
Mhm.
now, after this party or festival, I'm a wreck.
Yeah.
So, yeah,
So there's a couple teaching points in here. One is one that I think a lot of trainees have heard a lot, which is set and setting. The
yeah,
idea of like, really being conscientious about set and setting, which in this context is a clinical setting with what you named, with a therapist really sitting with you and tracking your experience along with you the whole time.
yep,
So
yep,
it's helped therapeutically while you're in the journey.
yep,
And then
yep.
there's preparation before, integration after, which we can break down a little more. And these are really the building blocks of basically how to do this work well. And unsurprisingly, these are also the places where when things go badly, these steps have been neglected.
Yeah, yeah.
I do want to circle back really briefly to one of the things you named, which is fear, because I think some people have a question about like if I'm afraid or nervous, does that mean that I'm going to have a bad experience? And
Yeah.
um, you named bad trips as something that you kind of screen for when you're doing this work with people.
Yeah.
And I guess I would say a lot of people come into our clinic nervous or having had prior negative experiences. We spoke a little bit to
Mhm.
working with that, but I think there's a difference between working with your fear in a sort of therapeutic way where you feel that the set and setting is controlled and that
Yes.
you have agency and that your therapist is like literally tracking that with you and talking to you about it,
Hmm.
but or being thrown into a place of like terror and just being out of, completely disoriented or out of control.
Right.
Um, and there's probably a lot in there. There's also people's, trauma histories are relevant. So really what I'm saying is I don't want the listener to take away the impression that someone being afraid of the experience means they can't do it.
Yeah.
But it certainly means that you need to do like a lot of work up front with them
Yeah. Yeah.
collaboratively
Yeah.
and make sure they are checking themselves really authentically and that they are actually really feeling ready to step into this in small ways. And you're not kind
Yeah.
of saying, oh, let's put you back under and see what happens.
Right. And so I think this is why it's important to really establish a strong therapeutic relationship that takes some time, perhaps, if a person has a lot of anxiety going into it. And you know, I think there's particular things to really get into in preparation. I actually have a preparation workbook that I give to folks if they're going to go do a thing somewhere, or when I use ketamine with
Mm,
folks. And there could be a preparation. I even have a preparation checklist that
right.
involves just personal history, education history, your trauma history. What are your fears? Let's get into this stuff.
Mm,
Um, yeah. So.
yes. So, um, yeah, I could really go. It's so tempting to want to go into a whole conversation around like all the things that should be in preparation because I think we have that in common. Um, but I'll just summarize that for this particular purpose by saying know how to do preparation really well. We
Right.
have modules on that, but having a checklist or having a thorough understanding of what's involved, I'm just speaking to the audience here, get a training
Yeah.
program that really teaches you that really well. And
Yeah.
we'll leave it there, but we'll kind of just highlight the importance of it.
Yeah. And
Um,
I like what you said about just fear and anxiety being useful,
mhm.
for allowing us acceptance of these fearful and anxious feelings to be a part of who we are, and I think internal family systems actually really works well
Yeah.
uh, with psychedelic kind of therapy work. So I think that the fear and anxiety can be really useful until it's overwhelming.
Yes.
Um, yeah.
And
And
for those
so
who
that,
don't know what that is, that's referring to parts work or the idea that, we have parts that are afraid or parts that are very protective and don't want us to let go of control, for example,
yeah.
aspects of ourselves that need to, have various ways of feeling safe in the experience. And one of the ways I see a lot is losing control is unsafe, right?
Hmm.
Or
Yep.
there's a lot of ways
Yeah.
that can look. But that Yeah, I agree with you. The important that those can be super valuable things to work with actually therapeutically.
Yeah.
So the fact that, your client has some fear is okay.
Yeah.
It's
And,
just don't
and I think
steamroll over their protector
that's
parts.
where the juice is, right? That's where
Yeah.
the juice is. Yeah.
So I wanted to make that distinction between a bad trip and sort of the fact that someone is nervous or afraid. The latter can be completely therapeutically valuable to work with. Um, so I'm curious if you've seen this. This I think falls under harm, but it's a more subtle thing, and that
Mm,
is like I have seen a tendency in some clients, which I guess is the phrase spiritual bypass is often used, but the idea
okay.
that like they're really using the psychedelic experience for kind of escapism from
Hmm.
distress and
Yeah.
then going back to it and kind of relying on it and that being counter therapeutic, but the provider not picking up on that and
Right.
almost accidentally aligning with it. Like,
Hmm.
yeah, we're going to get you into this mystical place. And that's like, now we've done you some good.
Yes.
I don't know
Yes.
if you have thoughts about that because
I,
that's,
I, I think I said this earlier. I call them bliss chasers.
yeah,
And
yeah,
maybe they've heard about the mystical experience, and that's where the real beneficial results and outcomes are. Or I've had this experience a long time ago, and I just want that again. And I think that there is a bypass because if you're chasing that or you want that, then you're not here.
yeah,
You're stuck there, and I think that
yeah,
we people's our anxieties, our fears, our insecurities, or whatever's holding us back uh on this plane of our personality and psychology, like that's where we need to really do the work, not getting out of that, like you said,
right.
escapism or bypassing all that stuff.
Right.
um
So
so
if you're a therapist, what this can look like is like the person will say things like, I feel healed when I'm there, like in the psychedelic state itself. Like I
yeah.
am healed now. And when I come back, like my problems come back. So I just want to go back to that healed place. Right.
Yes.
And
Yes.
yeah, it can be easy for an untrained or an unexperienced provider to be like, yeah, let's put you back in that healed space some more and just kind
Right.
of accidentally align with that. And
Yes.
yeah, I agree with you. Really, what they need to do is take some insight or some awareness or some shift out of that then moves into their actual everyday
Right.
life. And if I can keep going
So
back, yeah,
this is where integration comes in afterwards, right? Like, how do we take this experience and really make meaning of it that we can generalize into our life, not just this really cool, amazing spiritual thing we did once, and I want to do it again, and get there. Otherwise, we're
agree.
stuck there.
So what are some of the ways you see that integration go badly?
Well, too short.
Yeah.
Um, it, I think where it's just like a sharing circle, which can be really helpful to go to, in Asheville, there's a psychedelic meetup groups, like those can be helpful, but I think people can be not heard or dismissed if there's a groups or not really get their point across or feel really anxious when they're in a group and not be able to tell their story or find meeting. And there's not enough attention in group settings. So.
Hmm.
And I guess if you're with a therapist or just someone who you trust and you care about and you're trying to talk to, that they're not really attuning to your experience. Um, that's why I think a therapist can be really helpful because we're trained to do that.
Yeah.
Or somebody just doesn't even do any kind of integration and they just kind of carry on and go to work the next day.
Yeah,
And
I've seen that a lot.
yeah,
Uh, not and I see that a lot in people coming from underground settings, but even more than you expect, also from other clinical settings
yeah.
where they
I
kind
think
of
there
get
can be, like psychological kind of old trauma can come up and be unresolved during integration, even, right?
Mhm.
Um, and this the inability to make meaningful changes, behavioral changes. I really think that like we're more psychologically flexible after a non-ordinary state experience and neuroplastic, and I think making that stick with behavioral changes, which is going to take some persistence and discipline and choice. And I think that
And it
that's often,
really needs a one-on-one relationship. Like you're not going to get that kind of coaching or mentoring or nudging in a group sharing
yeah,
circle.
sure. And some people, might, I mean, I think it requires, like I said, it requires discipline and at least self-accountability to implement some behavioral changes. Otherwise, maybe psychologically, and we have this big emotional, even spiritual experience, and then it sort of fades if we don't anchor it with behaviors,
Hmm.
over time.
Yeah, there's this interesting connection there between the integration and the preparation stage to go back to,
Mm,
because I think people's expectations aren't framed always wisely. Like I
hmm
see people who they've gone into an experience and it's sort of been implied, if not outright said, that this is going to heal them or fix them.
Right.
And the provider doesn't say, you're actually going to have to do some work. Like this is going
Yeah.
to take some work here. We're not just going to wave this pixie dust over you today and then you're going to be
Yeah.
a changed person. And because that kind of one and done pixie dust experience does occasionally happen, it really does.
Mhm.
That's
Yes.
overrepresented in the media and in this
hmm
public discourse. And so I think a lot of providers don't do the work up front to say, hey, we're going to do these journeys and then we're going to do a bunch of work around it after.
Right. Right. Right.
And integration is going to be work. It's not always going to feel good either.
Integration is, just as important, maybe if not more important than the actual experience itself, you
Yeah.
know. And I think that, another problem that can occur post experience during integration, whether you're with an integration provider or not, there can be this sort of like psychological dependence on a medicine or a person, to keep providing. Like I think we can get stuck in it, and like I said, like chasing it to fix me. Um,
Yes.
yeah.
Yeah. You just touched on something there, which is another form of harm I think that can happen, which is this over attachment to the provider.
Yeah.
This is
Yep.
particularly vulnerable in underground settings where boundaries can be less carefully held, right?
Yep.
Um, where there's almost like a little bit of a guru phenomenon. Where
Right.
like, yeah, and
Yeah.
that obviously psychologically really can be in lots of subtle ways damaging for
Yeah.
someone and also under recognized by both parties.
hmm
If you are, a lot of this is another place where the providers often um
Yeah.
aren't aware that that's a kind of harm
Yeah.
that they're
There was
creating.
a whole
Subtle
in
one.
the CPTR program, like there was a whole uh lecture, maybe two lectures about spiritual narcissism and psychedelic narcissism. It's
Yeah.
like, wow, there's a lot of attention was paid to that. So,
Yeah. I mean, I'll say this to our listeners, you have to track yourself as a provider
hmm
because people are having incredibly potent experiences that may be something more potent than they've experienced in their life or certainly different than anything they've experienced in their life. Be
yeah,
very emotional, very intense. And they can project that onto you as the therapist
yeah,
in ways that sometimes overtly, but oftentimes it's in subtle ways that if you're not tracking for it, you can slide into a dependency on you or a sort of reverential
hmm
energy that the client will have towards you. And that's not a healthy boundary for them. And it's also a particularly sticky
yeah,
psychological territory. So, I mean, these are important to talk about because these are some of the more subtle things that I think aren't often overtly talked about enough in trainings.
yeah.
Um,
I had a client who, um, really holds some, belief in past life regression and these kinds of things. And he had an experience that the provider and he had many past lives together, including being lovers.
oh gosh.
So kind of oriented to that provider in that way, and
Wow.
wanted to persist with a relationship, And thankfully, that provider was like, oh, like held it really well. It was like, this is yours, this is where you're at, and didn't just reinforce it or validate it, from where that person was at. So very interesting.
That's really interesting, and I think that some of the more well-known or the more well-known incidents where the MAPS trials, the Lycos trials, had damage
Mhm.
that was not the exact same situation, but that kind of blurring of boundaries, which goes without saying. Um,
Yeah,
it goes against all of our therapeutic ethics, but those
right.
but can get blurrier with when you have psychedelics involved for the
Yeah,
client especially. And so
yeah,
it's
yeah.
our job to be especially vigilant on
Mm,
those fronts.
yeah,
Yeah, that's a an interesting one that I've definitely seen, and a more subtle one.
yeah.
Um, Thoughts on things that can go wrong during the actual the session itself, the administering of a medicine, or the way that um, the therapist engages with the client on the medicine. Have you seen um, patterns
Yeah.
there?
Well, I think that, there can, what we might call like psychological fragmentation, where, um, you know, deeper held pain, sufferings, traumas, wounds can, be unearthed, excavated, and people can really blend with that. Um, and that can be very useful, but has to be handled very, adeptly by the therapist, or, to be able to work with that. So I've seen that happen.
So it's really almost an argument for having really good therapy skills. Like
Mm-hmm.
almost, this is something I feel like I say a lot. There's a there's a lot of people doing this work who have what I would call sitter skills. This comes from
Right.
underground, where like I'm
Sure.
really comfortable being with you while you're on this journey. But that's
Yeah.
not the same as knowing how to do trauma work with someone if their trauma is coming up.
Yes.
Um, and so my personal bias is like having a strong psychotherapy background and knowing how to do trauma work, and
Mm-hmm.
ideally even somatic interventions if needed. And
Yeah.
um, because yes, I imagine it's, my experience has been, and I'm curious if yours is similar, that people will have really hard things come up in a journey, often complex trauma pictures and things like that. And the sitter will just sort of sit there with them,
Yeah.
and then it'll be done, and the sitter will make sure they're sort of oriented, and then chat with them about it.
Mm-hmm.
They'll sort of, and then go.
Right.
But the trauma content is not worked with. It's just stirred up
Exactly.
with some,
Exactly. Yeah.
and then the
So,
person is really dysregulated and scared.
yeah. Yes. Yeah. I think it does take some intervention. It's like sitting is sitting, facilitating or guiding, that's something, but, therapeutic interventions when difficult material is really, blended up. Really risky behaviors can ensue, or at least, panic can happen. And then this can persist if it's not handled well by someone with
Yeah.
some real therapeutic interventions. You know, sometimes I teach people, breath work practices just in my own
Mhm.
practice, anyways.
Yeah.
But if someone tells me that they had a difficult psychedelic experience, or they're planning to, have some experience down the road, I almost always teach them some breathwork skills, and some somatic, posture work. Um, yeah.
That I think that that would be extremely valuable. And because want to speak to an audience that may not have breathwork skills, I will
Mhm.
say my thought on this is that's actually an amazing thing to study if you have the resources and ability to do it. Those of you who are stepping into this profession. If you don't, I think the broader message behind what I hear you saying, Derek, is have some way of helping the person use skills to regulate,
Yeah.
whether it's, some people use mindfulness cueing or other kinds of somatic touch. Obviously, you would collaboratively work that out.
Sure.
Um, but breath work can be an amazing way to do that. So, um, I think some of my take homes that I would like the listener to to take out of this conversation, if I had to kind of crystallize, really, I think my interest in interviewing you, Derek, is really to get the word out for new providers. Like, think about this. Don't just go out and be like, I have no plan. If something goes bad, I guess like, I'm kind of stuck. Because
Yeah.
that's happening a lot. One of the first take homes that I've heard you say is have a referral network if you actually have a psychiatric outcome that's damaging. Like if someone does develop psychotic symptoms or
Yeah.
gets, stuck in a manic situation or becomes more suicidal, is
Yep.
you maybe if you're going to go into like psychedelic psychotherapy, have a established referral network for that. Like know where you will send someone in your
Yep.
network, and that may not be easy to find, but it is whole. You have to do that.
Yep.
That
Yep.
is not something to mess around with because then people are just getting stranded,
Yeah.
like you named, and
And it's not only, I think it's not only like new providers, but I think people who have been practicing for a while in whatever mode or tradition they do to really like get some peer support and peer discussions going on with people who know about this, and really actually be checking your own consciousness around your skill and experience and check yourself before you go into something.
mhm.
Um, it's not just like, okay, so and so is coming over and we're going to do this thing for some hours today. I think there's like the practitioner needs to prepare, you know?
Yes, there's an over casualness that
Hmm.
see like that's
Yeah.
a big deal. Like,
Yeah.
well, okay.
When I'm going to do a ketamine session,
Yeah.
wow, I make sure like that morning I'm settled. I'm in myself because if I've got some of my stuff coming up or parts of me that want to be a really good ketamine provider, if I've got that part really up, I'm not going to be relaxed and open to what's going on with my patient, you know. So I think there really needs to be a lot of emphasis for the provider taking care of themselves in that way.
So I'm hearing a couple of things. One, I set referral networks for if you do have like a concerning outcome, whether that
Hmm.
needs to be medical or psychiatric, or and then peer support
Yeah.
for kind of ongoing supervision
Yep.
for you tracking yourself as a provider, that you're not stepping in over your head, and that you have someone to talk to about tricky dynamics or concerning dynamics and things like that, or maybe get support.
Yep.
Um, there's also, don't go into this work if your main skill is being a sitter,
Hmm.
and make sure that you
Right.
actually have a psychotherapy background to work with trauma content or other kinds of challenging content that comes up.
Yeah.
Otherwise, you may stir something up for your client that you're not equipped to then
Yeah.
address.
Yeah. I
And
had a couple ketamine sessions scheduled for late, late October, and the hurricane hit,
yeah,
and I was not ready. I wasn't in the right space I wanted to be in to go do that. So I canceled it.
yes. Reminder, we were in Asheville, North Carolina, both of us, where that was,
Yes.
but you're speaking to regulating yourself and taking responsibility for going in fully in the right space
Yeah.
so
Yeah.
that you can fully attend ethically to your client.
Right.
Um, so some other take home points, and some of these are big asks. So some of
Yeah.
you who are out there getting into this work, we're saying have a referral network, have a peer support network, and supervision. Get maybe better skills, actual therapy skills. That's a big ask. That may involve a
Yes.
lot of training.
Yeah.
Have some tools for helping people regulate, like you, Derek, have named breath work, but um, working with fear states and things like that. That also falls under therapy skills.
Yeah.
And so this may involve getting more training, but if these are sort of a checklist of things that maybe don't go into practice unless you've really put some thought, and you can almost say, okay, I have this and I have this and I have this.
Yeah.
Um,
Yeah.
thoughts on where to get supervision? Is that something that you do or that you point people towards, or
I've worked with a few, so upon leaving the CPTR program and the vast network of people that I connected with, I've got a couple colleagues that I work with. not supervision, but perhaps mentoring in a way, and yeah. And I work with some other therapists in Barbados and Trinidad, and doing ketamine work. And so I'm sort of supervising mentoring trainings to other therapists there as well. So, but where to find that? I think it's just, uh, gosh, maybe the Maps Lycos website might have integration therapists just to have a network, you
Yeah.
know?
Yes, and supervision is LMI has supervision available. Some of our providers do that for new career psychedelic psychotherapists.
Yep.
Um, and someone like yourself sounds like a resource. And so it's beholden on you guys, you listeners, to go find these things.
Yeah. Yeah.
And it's not always easy. It takes resources. And this is where I say a lot to our trainee cohorts, like, um, being a psychedelic psychotherapist is a huge responsibility because of this vulnerability that people have and our capacity to do harm. And so I think that what I see a lot is people taking the easier road because it's expensive, or you may need to go back and get more training,
Right.
and just kind of assuming that they'll be okay with and getting and then you're gonna it's definitely, both Derek and I have witnessed these cases where things can go badly. So
Yeah.
it may be that more training is involved, or you doing the internet search involved to get a supervisor for yourself, a
Yeah.
supervisor who does this work, and a peer support network.
Yeah. And I think in some ways, like for providers doing their own work, and if they have access to ketamine, for example, have those experiences safely with a provider. Breathwork to have, a non-ordinary state experiences on their own um, can be really helpful to know the terrain, so to speak, of person that you may work with who is having difficulty. Yeah.
Well, I think those are some really valuable take-home points. If people want to reach you, I'll just say your website is clearlifenorthcarolina.com, but North Carolina is NC. So CLEARLIFENC.com.
Correct.
And
Yeah.
your email is derek@clearlifenc.com. That information will also be on the link below the episode.
Yeah.
So if people want to reach out to you that way. Any last minute thoughts or advice or anything that you would like to put out there before we close for today?
Hmm. Well, you know, like these are powerful substances, and ketamine is at the forefront and legal, and thankfully we have that. And as we go on, wherever this goes in a post approval world, um, they're powerful substances and need to be handled really carefully. So much uh, healing and joy and expansion can happen for people, and people can be harmed as well. So I think there needs to be a lot of care. And these substances, other substances have been used for thousands of years. Um,
With,
and
with care.
with care, oh, that's the thing, with care. Yeah. So, yeah.
Yeah, thank you. I agree. Maybe our biggest sort of message collectively today is people want to put this in a box, like psychedelic work is either good or it's bad and dangerous. And
Yeah.
we have a hard time in our modern Western world with the nuance of both and. That
Right.
it's powerful and it can be it can be heal and it can harm.
Yeah.
So we have a responsibility to name that and to show up for that in the most ethical way we can.
Yeah.
So
Great.
thank you very much for being on. Really
Thanks,
appreciate it.
Cindy. Yeah, great. Thanks.
Thanks for listening to Living Medicine. We'll see you again next time. Be sure to click subscribe to get future episodes.